I want to talk about some of the clinical ethical perspectives, and then Alberto will go on and talk about more medical ethical perspectives, and we've got joint speakers for the regulatory narratives, which I will introduce as we go along. Actually, I think a lot of what I'm going to say has already come up in discussion, which is really nice, because I think all I'm doing now is reinforcing points that have already come up. So what do we do about this going from principles? So in a way that the sequence is the wrong way around, because I think Alberto will talk much more about ethical principles, and I want to see how clinical ethics lands when a result enters a 10, or perhaps generously, as Deborah said earlier, 15-minute consultations. What do we do? What's come up a lot today already is that we live in a very techno-optimistic society. I think there's often a belief that a test has intrinsic value rather than that it is dependent on the context in which it arises. And I'm sure that's very influenced by social media and what we were just hearing about, the sort of quick attention-grabbing TikTok society. So I want to ask some sort of broader questions about whose data are shaping these tools and for whom does that matter? What does it mean to integrate commercial products into publicly funded health systems? So I think what came up at the last discussion was, well, what direct-to-consumer testing could be funded through the NHS? And I think that's a really important question. And why is that not happening if it isn't at scale? And just to put into context, I can sort of get these different perspectives. So in my PhD 30 years ago, I worked on some very techie aspects of genes that were provided susceptibility to certain diseases. And in my thesis at the end, I wrote very enthusiastically that the genetic factors I had found would soon be translated into the clinic. And I think 30 years later, when none of them have been translated into the clinic, I still think that as research findings, they said something very important about risk factors to disease in a population. But as individual predictors, they are pretty meaningless. And there, I think, is a really important leap, that we so often hear of exciting research developments on a population level, and we imagine that that will translate into effective personalized medicine. But in many areas, the absolute risk they produce is very marginal compared to the relative risks that findings might produce in individuals. And I'm not going to talk about this, but I think that polygenic risk scores are a really good example of that. Really important on a population level, but on an individual level, I would argue that their impact is quite subtle at best, but often the discourse around them is that they show huge promise, and if they don't deliver it just yet, they soon will do. So I think context is the most neglected part of the story in this rapidly developing field. So clinical interpretation, as everyone in the room will know, is contextual and not just analytic. The ethical work here is done when someone decides what that value means for this person with this story in this setting and in this system, not the result itself. As Rachel has told us, a diagnostic test, for example, a BRCA2 variant in the context of a young onset cancer, may have a very different value to if it is found in the screening setting. So UK Biobank data show very nicely that there are many participants who are in their 60s and 70s who have BRCA variants who don't appear to have cancer or a family history of cancer. So finding it in the screening setting is very different to finding it in the context of a family history or in the context of already having had cancer. The difference between diagnosis and screening is a really important one here. And it's different again if you use a direct-to-consumer ancestry test, which may only look for some of the variants that are encompassed by when we talk about the BRCA1 or BRCA2 gene. And as Rachel has highlighted, there might be high false negatives there, but there might also be high false positive rates. And the really concerning examples have been in my clinical practice of people wanting risk-reducing surgery for what they perceived as a very high risk that simply was not there. And I mentioned this morning, but just again, the CPM annual lecture that Trish Greenall did last week talked very effectively about the importance of combining personalised medicine, which we often think of in very technical terms, with personalised care, what it means for the patient in front of you. And that lecture, if you missed it, will soon be available on the CPM website. The pre-test probability, the indication for the test, and the clinical history all matter hugely in interpreting the test result. I think clinical ethics is about how we provide that context. How do we weigh the uncertainty and include patient narratives when confronted with direct-to-consumer results? And that will include things like Rachel's already mentioned, that people who have paid for their test might quite often think that therefore that test is better than an NHS test because they've paid good money for it and it's been sold to them with strong promises. I think it's important to remember that the same laboratory value can mean very different things in different clinical contexts. DTC tests are often used in asymptomatic, self-selected users, not in defined pathways. So again, the narrative of prevention is really important here, but we must look within this conversation about who that narrative is for and whether that prevention actually translates into money saved for the NHS or extra money for the NHS in terms of new journeys created as people need new follow-up or new check-ins. So just again, this has come up a lot today, that there's a really important difference between diagnosis and screening. I think many direct-to-consumer products are marketed as tests, suggesting diagnostic and strong predictive abilities rather than as a screening test. In practice, they may best function like screening people without symptoms or clear indications. And the crucial thing there is that in screening programs, a positive result is understood as needing further confirmatory testing. So you go for your mammography, or you go for your you have your bowel screen. I think most people understand that's a screen, and if the screen comes back positive, that might be worrying, but you know there's a further test that can be done to tell you whether you really are in the diagnostic group or not. But screening itself has opportunity costs. The reason that the National Screening Committee screens for so few things is that it has to very carefully weigh in the balance the cost of screening a population with the benefits that arise from that. By opportunity costs, I mean that if in a publicly funded health system, we are doing one thing to a large group of the population, that means taking away hip replacements or something from that pot. So we always need to weigh that in the balance. I think it's very interesting that the National Screening Committee often has a reputation for being rather sort of slow and truculent and not willing to offer evidence-based screening, whereas actually it's very meticulous on how it weighs up the evidence as to whether the overall benefit of a screening program is indicated with that opportunity cost in mind. So the performance of the test is not the same as positive predictive value. Rachel's already mentioned that. I'm going to just give you an example in a minute. And the next step, that next step for a screening test might be clear in population screening programs, but in a direct-to-consumer pathway it often isn't, so that people are left to interpret their results on their own. And this is one example from 2022 prenatal genetic diagnosis guidelines, so NIPT, non-invasive prenatal testing. There's a case there, which was, these are all anonymized cases, but it was a case that represented a lot of issues coming up for the community. So Elizabeth was 15 weeks pregnant. After a dating scan, which was normal, her partner bought her a non-invasive prenatal test from a private provider as they wanted to check their baby was healthy and find out whether they're having a boy or a girl. They were very upset to be told there was a high probability that the fetus had trisomy 13, Patau syndrome. The test was advertised as being Actually, there's a typo in the guidelines, 99% accurate, whereas in fact it's 99.9% accurate. And Elizabeth then calls her GP to request a referral for termination of pregnancy. Now, Rachel used the same example and said 99.99% accurate. So these tests do get more and more accurate. But what I want to illustrate to you is that accuracy of the test is not the same as positive predictive value, particularly when you've got something that's really rare. So 1 in 10,000 babies have Patau syndrome. It's a rare condition. 1 in 1,000 tests, 99.9%, are false positives. So if you're doing 10,000 tests, for the health economists and the statisticians in the room, please forgive this sort of simple Bayesian calculation here. If you're doing 10,000 tests, there will be 10 false positives, because 1 in 1,000 tests are false positives, and 1 true positive. So the chance that a 99.9% accurate test is a true positive is only around 10%. So positive predictive value is really dependent on the context in which you're doing that test. If you've got something really rare, then even if you've got a 99.9% accurate test, it will not predict very well whether that's a true positive or not. And if you're doing that in a healthcare setting, that might be hard enough to explain. But if this is a direct consumer testing where there is no other follow-up, then perhaps it's not surprising that Elizabeth asks her GP to for a termination of pregnancy. So again, this has come up a lot today. Many direct-to-consumer data sets are built on early adopters. Training and validation often reflect health-engaged, relatively advantaged users. We talked a bit about ancestry making a difference in different talks already, but more generally, risk estimates and normal ranges simply may not be known. We may have a range in a certain population, but we may just not have enough data on a large enough sample to know what the limits of a normal range are. And going back to my early days as a junior doctor, I remember we used to say that pregnant women all needed iron because they had a iron deficiency anemia, whereas in fact it was just the blood volume that went up in pregnancy. That's now well known, but those sorts of normal ranges are often not known for these sorts of direct consumer tests. So when such tools or reference ranges are imported into NHS practice, they may not apply well to people with different ancestral backgrounds, comorbidities, or social circumstances. The equity problem we've talked about, but those are already better served by health systems are often overrepresented in the data that shape the new tools. Social determinants of health. Postcodes are often as predictive as genetic tests of future ill health, and that's something that many people don't understand to be the case. And again, it's come up today that many clinicians may not understand or feel equipped to deal with a result they've previously only seen in a diagnostic setting. So they've only seen it in the context of an illness, and then it might mean something. But in the context of a direct-to-consumer test, without any signs or symptoms at all, it may be very difficult to know to know what to do with that result. This is one of the really key issues I think that's come out throughout the day, but is worth another mention, is that we live in a society where our optimism around technology is huge, and our narratives are very techno-optimistic, I would say. Does more testing, more data equal better care? I've yet to see the evidence that it does, but we often believe that it must do, that it's only around the corner that this massive data set will actually produce something better. Neglect of context is one of the greatest philosophical disasters of the modern age. Alberto might tell me who actually quoted that originally. I can only find McGilchrist, who talks about it, and John Dewey, but I think it's really relevant to this discussion that context. Narratives of optimism can obscure uncertainty, false positives, and overdiagnosis. False positives and overdiagnosis are not the same thing, but the opportunity cost is a really important one that's often not discussed. And I think there's an ethical imperative to examine these unintended consequences. In clinical ethics, we need to ask more basic questions. What is the pretest probability? What is the evidence of net benefit? What happens after this result appears in the record? What new journeys are created? So we talked a lot about diagnostic odysseys taking a very long time in genetics. That's been well discussed, but also we heard about endometriosis. Endometriosis taking some 9 years for a diagnostic odyssey. If we start screening people and following them up to see how their data changes over time, we might be creating all sorts of predictive odysseys that are just as costly, both in terms of money, but also in terms of experience of that journey. This might be my last slide. I use it in genetics a lot, but I think it's relevant to what we're saying more broadly about data. A genotype does not translate linearly into a phenotype, into signs and features. What actually happens is like a prism. So you start off with a genotype, or biochemical data, doesn't really matter. And then in this prism, we have developmental factors, environmental factors, random factors such as our immune system, and ancestral variation that split the possibilities into a prism of lots of different colours. So on the one end, you have a very severe phenotype, and on the other end, you have no phenotype at all. So starting with genotype doesn't tell you which end you're going to end up in. So if you start with a very severe phenotype, then going back might help you. It might help you confirm what that phenotype is due to. But if you've got no phenotype at all, it doesn't really tell you what that genotype is. And if you start with a genotype, actually the prediction that you make at the end of it is very noisy. So you might have to follow hundreds of people to find one person with the phenotype that in the past has been associated with it. So I think it's not a moral criticism to say that commercial companies have to sell their products. And it's not a moral criticism to say that the NHS is under strain and often sluggish. So how do we get those two to talk to each other and have a meaningful conversation? Now, I think we've seen lots of evidence of that today already, but how can we keep that going? I think it's ethically also very naive to think that these two factors, the need to make profit out of your commercial venture and the difficulties of running a public health system that was created in the 1940s and has seen a lot of changes, that those don't shape how tests are framed, which outcomes are emphasised. And in direct consumer testing, we've heard today already that often we're measuring engagement metrics rather than health outcomes because they take too long to acquire. And which burdens on public health systems are downplayed. Procurement and partnership decisions are ethical decisions about whose interests are served. I think this is my last slide. So we need realism about integration. We're not arguing that all direct-to-consumer testing is unethical or unusable, or that the NHS is useless. We need ethically literate, can't say the word, realism about what these products can and cannot do, how they are affected by context. Keep a keen eye on the difference between diagnosis and prediction. Think about techno-optimistic values. Data rarely stand on their own 2 feet, but often are believed to. What new journeys are we creating in endeavours to prevent and early detect? And what safeguards and supports do clinicians need in this new territory? I think we need to build pathways that acknowledge real resource constraints and how we balance that with private profits and public burdens. Oh, and last point is off the bottom of the slide, I think. We need to recognise the limits of what regulation alone can fix. Context-sensitive clinical judgment will always be required.